And our purpose here is to empower the healthcare providers in the community to deliver age-friendly healthcare. Next slide. Okay, so about ECHO, this is a forum for mutual teaching and mutual learning, and this will be all teach, all learn. So we invite all of you to, participate and engage with us and with each other during this session. Next slide. So a little bit about our format. After a short lecture from our experts, we're going to share expertise from the rest of the team and then open it up for a time of case discussions. So we invite you to share any geriatric cases, even if it may be on a topic not related to today's lecture. Our team here is willing to teach and share our collective wisdom with you, and we only ask that you keep it HIPAA compliant for discussion. Next slide. So yeah, it needs to be, we commit to confidentiality and HIPAA compliance and create a safe learning environment where we encourage each other. And we note that ECHO case consultations do not create or otherwise establish provider-patient relationships. The purpose of these sessions are purely educational. Next slide. So this is our calendar. We run the series on the second Wednesday of each month from 12 to 1 as a 1-hour session with continuing credits available for physicians, for nurses, and social workers as well. And this is our calendar for the next few months, so you can plan ahead and join us. And if there are topics that you would like us to cover in the future, please let us know in the chat box and when you complete your evaluation form. Next slide. So some Zoom logistics. You can move your mouse to the bottom left and you're going to see that mute button and the chat button. Next slide. And click on the chat tool and please enter your name and your discipline and your organization so we have a record of who attended. That would be great. Next slide. And also there's this mute and unmute button. So make sure that it is muted while you're not speaking so you don't hear extraneous noise. And then of course, unmute. We encourage you to unmute when you speak. Great. Next slide. And in order to receive CMEs, you have to register if you haven't already. You can still do so after you get out, complete the session, and then also complete an evaluation as well. And that link will be texted in the chat box towards the end of the session. Next slide. Okay, so I'm just going to introduce the hub team here. So that's me, the course director for this ECHO clinic. We have Mary Gotham and
hi.
There she is. Yeah, Hawaii Department of Health. She's currently retired, but she has decades of experience in public health nursing. And Sarah Tompkison, I'm not sure I see her here today, but hopefully she will join us shortly. And unfortunately, Chad, who is always here, is on military duty. So we just applaud him for serving our country so well, and he'll join us when he's done with his line of service. And next slide. And yeah, so today actually I'm going to be speaking, but we also have Monica Esquivel, and she can wave hello over there. And yeah, she's an assistant professor and program director at the Department of Human Nutrition, Food and Animal Sciences at UH Manoa. She received her master's degree at the California State University Northridge and her PhD at UH Manoa in nutrition. And that both speakers have disclosed that we do not have any relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. So I'm just gonna take a look at this chat box because it looks like we have lots of cool people online. We have Joseph Cohn from Maui. It's good to see you again. And we actually have Allison Sedurko from Maui. We have a bunch of registered dietitians on us, so I'm very excited about that. We have some geriatricians as well. I see. Hey, hi, Serena, Lowe, Dr. Lowe. And we have folks from HMSA. We have Kevin Wu at Manoa Cottage, and another Leanne from also a dietitian in long-term care, folks from hospice and Arcadia, lots of social work and dietitians. And so, yeah, so this is, oh, and Dan Saltman is always here. I'm so glad to see you again, Dan. So, yeah, so great. So let us, is there anybody on phone who needs to identify themselves? No, nobody's on phone today, hardly. I see. Okay, great. So I guess we'll go ahead and get started. So here we go. Okay, so next slide. Yeah. Oh, so yeah. So today, learning objectives is that we're going to talk about understanding the nutritional needs of older adults, be able to recognize and evaluate undernutrition, and know what resources are available to manage undernutrition in a way that maximizes quality of life. Next slide. So yeah, malnutrition is really common. It's present in about 13% of older outpatients and about a quarter to half of hospitalized older adults and more than 50% of nursing home residents. Next slide. A lot of the content that we're going to cover today is actually from the AGS GEM toolkit, the Geriatrics Evaluation and Management Tools that you see over there on nutrition and weight loss. And actually this can be downloaded as a PDF on the resources on the GWEP website. And you can, it's just a really quick 2-page summary, and it's a really handy reference. So, so feel free to go ahead and pull that up for your own reference. Next slide. Okay, so okay, just a little bit about age-associated changes. As we get older, we have a lower bone mass, lean mass, and water content, but more fat mass, unfortunately. And also basal metabolic rate is reduced due to that loss of lean body mass. Next slide. Okay, this is an example of the older adult food pyramid guide. There's, you know, the Monica can probably talk a little bit more about that choosemyplate.gov or something like that. But older adults have a little bit different needs than younger adults, younger adults. And, you know, in particular, you know, like I just love here that they have this extra little circle on fluids. Because they're just so prone to dehydration, and we don't pay attention to that. They get easily dehydrated, and so, and of course, attention to some of these other needs that we'll highlight in the next coming slides. Next slide. Okay, so this is the fluid needs about older adults. So yeah, as people get older, there's a decreased thirst perception. And so as the body's chemistries change with the serum osmolality, and the ability to concentrate urine also changes. The kidney doesn't function quite as well as it did when it was younger as well. So those things contribute to older adults not drinking enough. Fluid needs are actually about 30 cc's per kilogram per day. And so for, say, a 120-pound person which is about 60 kilograms, that calculates to about 1,800 cc's a day, which is quite a lot to drink, I think. But that's what's needed to function optimally. Dehydration is the most common fluid or electrolyte disturbance in older adults. And we should try to include dairy drinks, not just water, because this will also provide protein and calcium as well. Monica, do you have comments on this at all?
You know, that just to mention, you know, the benefit of including, and when we say dairy, there's alternatives than just milk, but we have like fortified soy products that also now for folks who aren't drinking dairy that have some of those nutrients added to them to kind of make them more equivalent to something like milk. But yeah, that's all. Thanks.
Yeah, and soy milk has plenty of protein too, and plenty of calcium because they add it all there, right? So it's almost like drinking milk. So yeah, no excuse, right? Nah, next slide. Okay, so believe it or not, we need fat too. Everybody is like, it's been drummed into them that, you know, fat is bad for you, but there are healthy fats, and fats are important to keep the body warm, right? And help the body absorb fat soluble vitamins, right? So, you know, we should be including in the diet unsaturated fats, nuts, olive oil, fish, avocados, those kinds of things. And that 20 to 35% of calories come from fat. So what are your favorite recommendations, Monica, for fat in your diet?
Oh, so any sources of omega-3 fatty acids. So here you have things like salmon, the chia seeds, other types of seeds are good for omega-3 fatty acids. And so that also helps. There's some support for lowered inflammation with those types of fats. Those are great. And then that age-old myth about eggs and the cholesterol, you don't have to worry. So when you have your patients, and most elderly, you probably aren't too concerned about keeping their cholesterol low, but I always like to make the plug that, you know, the cholesterol from eggs is not going to ruin anyone's cholesterol level. So don't feel like you have to omit the yolks there.
Yeah, and you know, another thing I discovered, well, like last year, was you can make chia seed pudding. It's really quite good. It's you just put it overnight in the fridge and it comes out, but just packed full of nutrients, and it's quite tasty too. Anyway, so yeah, I see. Actually, we have a whole bunch of things in the chat box, and how about we'll come to them at the end. Maybe we'll just go through them, because otherwise I'm going to have trouble looking at both sides. Okay, next slide. Okay, so carbohydrates, you know, everybody wants to do the low carb diet, but actually carbohydrates are good too. And they're very important for energy. Interesting, there are healthy carbohydrates that we should really pay attention to. That include fruits and vegetables as well. Some starches, especially whole grain, and 45 to 65% of calories should come from carbs. And each person should have about 130 grams of carbs per day. And energy needs is actually based on body weight. So for a 60 kilogram person, it's about, you know, 1,800 calories. So yeah, so carbs isn't just cakes and bread and pastries, right? So what do you usually recommend for older adults on a budget who need good carbs?
Yeah. So, you know, remembering like our starchy vegetables, the grains and things like that, of course. But when we think about fruits and vegetables, and with a budgetary concern, remembering that canned and frozen options are just as good as those other whole, you know, fresh fruits and vegetables. And those can also be helpful for processing. So sometimes, you know, cutting the cauliflower and some of those other vegetables can be hard if dexterity becomes an issue as we get older. Another thing to mention about carbohydrates is with the dietary fiber. I think we're going to talk a little bit about that later, but these are all also really good source of dietary fiber. And the idea of promoting some of these whole food sources of carbohydrates versus some of those more processed, refined grains and simple sugars is that, you know, there's a lot of research that's emerging of the high simple sugar intake and the negative effects on inflammation, and inflammation we know has a lot of detrimental effects on our health and functioning.
Yeah, so for a person, say, who can't chew, right, and is like on a puree diet, like they can still get carbs, right?
Oh yeah, they're probably the easiest, things, applesauce, bananas. I have a 1-year-old, so I think, the things that he started, even the squashes, some of like the winter squash or butternut squash, those things can be softened down and kind of mashed. Important also to think about all the different colors of fruits and vegetables there too. Yeah.
Yeah. Yeah. So I like that concept, expanding that carbs to all fruits, vegetables, and starchy vegetables as well, and including poi, right, in Hawaii.
Oh, absolutely.
Yeah. Yeah. Next slide. Okay, and we have protein needs as well. The protein needs is 0.8 grams per kilogram a day, or 10 to 35% of total energy. So, and of course, if you have stress or injury, like you have pressure ulcers or fractures that need healing, things like that, of course, your protein needs are going to be a little bit higher. So a 60 kilogram person would need about 50 grams of protein a day. So if you kind of take a look at some of these protein, some of these items here, yeah, this would be about most of your requirements a day if you have 1 piece of salmon or a third of a pound of steak, or actually, things like that. So it's you could sort of put together, like if you have one, like even twice a day, you can actually, it's not too hard to meet that 50 gram protein a day. And if it's really, really hard, Ensure Plus, I noticed, has 16 grams of protein within one bottle. So that can certainly be your protein supplement. If you're not eating anything at all and you're just doing Ensure, like 3 bottles of these will meet your, not that that's what we recommend, but yeah, there's plenty of protein.
If you're in a bind and that's what's working, that's fine. But one of my favorite sources of protein, tofu, is another really good one. Soft. Also, if any kind of problems with dentures or things, but tofu is another really good, strong source of protein for our populations.
Right. And we tend to think eggs and things like that, but Greek yogurt has a lot of protein too, which I was kind of surprised to learn. So yeah.
But I don't know if the secret might be out, but Greek yogurt is just strained yogurt. So it's just yogurt that's kind of been strained. So it's just more concentrated, and that's where we get all that protein.
Yeah, and definitely concentrated foods for people who find it really tiring to eat, right? Is really important. And we can talk more about that later on when we talk about difficulties getting the nutrition in. Next slide. Okay, and these are, fiber requirements. Men actually need more fiber than women. And just to note that here are some top high fiber foods. And so, yeah, you don't have to just eat cardboard and benefiber, psyllium, and citrusol, because that's actually insoluble fiber for your bowels, but you actually need like soluble fiber for your health as well. So yeah, what are your favorite recommendations for older adults?
For fiber, the other key, it goes back to fluid. So it's making sure there's adequate fluid to help, some of the soluble fibers, they're pulling fluid into the digestive tract and softening stool. So it's also important. That's kind of always my key go-to reminder, that is, as we increase fiber, we also ensure that fluids are adequate as well.
Mm-hmm.
And you'll notice, like, looking at foods, like some avocados, we have really local avocado, like all different varieties. Some are stringy, that's a sign there's a little bit more fiber. Some are really creamy, they might have a little bit less fiber. So also knowing kind of your food sources, that's helpful too.
Yeah, I don't see papaya in here, but a lot of folks like to eat papaya as well, right? So that should also count as a high fiber food.
Yeah, there's some fiber there for sure.
Yeah. Okay. Next slide. Okay. Micronutrients. So calcium, vitamin D, vitamin B12 are the key ones that we need to pay attention to. So folks should be drinking 3 cups of fat-free or low-fat milk throughout the day. And of course, as we talked about, if you can't tolerate milk or small amounts of yogurt, buttermilk, hard cheese, or lactose-free foods. And of course, we talked about those soy milks, hemp milks, there's oatmeal milk, there's coconut milk, there's tons of alternatives that we never had before, and they add calcium usually to everything. If you kind of read the labels there. And of course, consume foods that are fortified with B12, like fortified cereal. So reading all the labels and making sure that everything is packed with as much as possible, that would be ideal. Next slide. Okay, so nutritional screening. So this is the BMI chart that we like to look at. So BMI is calculated by weight in kilograms divided by height in meters squared. And of course, you know, it has to be interpreted in context of lifelong weight history. There's some people who are just like string beans, and they're like that all their lives. And so just because they got older didn't mean they suddenly become malnourished. You know, it sort of has to be interpreted in context. But the more concerning, but you know, if you have a BMI that's less than 17, that means you're less than this light blue bar and you're in dark blue, severely underweight. That's a really bad sign. And so, but the things that you need to look out for is basically loss of weight, loss of 10 pounds of usual body weight over 6 to 12 months, and inadequate intake of 25 to 50%, the recommended daily intake. And this type of malnutrition predicts functional limitation, need for hospitalization, and healthcare costs. And I'll tell you, I have a lot of patients admitted to the nursing home who have basically admitted for malnutrition and failure to thrive because they just can't seem to meet those nutritional requirements out there. And they definitely come in with functional limitations and infections and pressure sores and things like that because they have lost so much ground and have been in this zone, this dark blue zone. What's your actually, I think it's the next slide. There's also other screeners. Next slide. Yeah, so these are other nutritional screening tools. So there's a simplified mini nutritional assessment, the MNA. And actually, there is a website you can go to pick that up, or you can actually go onto the our website as well, and you can download that. And professionals could use the Determine checklist or the MNA as well. Do you want to comment on what you usually do?
So this is actually these screening tools are really great for both inpatient or in facilities. And these are often what might trigger a consultation for the registered dietitian. So we have so many registered RDs here on the call, which I'm really happy to see. And once the RD is visiting, they can do what we call a nutrition focused physical exam. And so it's a kind of newer in the last 5 or 10 years practice of kind of really looking for losses of subcutaneous fat, changes in hand strength and things like that. And so this tool is these are really great assessments to do both in the community setting to help trigger that referral to the dietitian for more in-depth assessments.
Okay, next slide. Yeah. Okay, so so what should we do from a medical history standpoint? I think we have clues that we can look at to see who's at risk. So folks with chronic diseases such as congestive heart failure, COPD, chronic kidney disease, conditions of chronic inflammation like rheumatoid arthritis, other GI problems, malabsorption, neurodegenerative diseases. These types of things put people at risk for malnutrition. Or if they're on a restricted diet from chronic disease, if they say, oh, you know what, I have diabetes, so I'm going to avoid everything. That happens, unfortunately, or kidney disease, they avoid everything. Also, what happens if they have polypharmacy? There's plenty of adverse drug effects. So we need to be very careful. So when we have patients with who are just not eating quite right, it's really important to just take a look at all of their drugs. Maybe go through it with a pharmacist as well to think about, oh, what are the ones that really that might contribute and what can we take away or change? Of course, cancer, depression, cognitive dysfunction, where they don't remember to eat or don't know how to prepare their foods, Dysphagia and dental problems. Don't forget dental, right? That's really important. But yeah, if you see any of these things on your list, you have to screen for malnutrition, and don't wait till they're really severely malnourished, of course, right? Screen early. Next slide. Okay, and social history is really important to take a look at. Gosh, are there problems obtaining food, like money, transportation, functional limitations, ability to open packages and prepare foods? You know, if there's low education or poor eating habits, look for social isolation, decreased activity and mobility. Alcohol is substance use disorder, right? If they fill up with all those calories, they're not going to be hungry for actual real good food. Mental health and history of neglect or self-neglect, which also is a very common thing that happens, and you know, we might need to consider involving APS if that's the case. Next slide. And yeah, here's a note about drug nutrient interactions. So, you know, there are some drugs that, you know, as I mentioned before, can cause anorexia. Things like digoxin, phenytoin, which is dilantin, cholinesterase inhibitors. Like a lot of people on Aricept, but you know, I watch really closely about their appetite. If there are changes in appetite or the GI symptoms, then you know what, it's probably not worth it to maintain it if they don't tolerate it. SSRI antidepressants, while they're helpful for reducing depression symptoms, it can cause anorexia as well. Proton pump inhibitors, calcium channel blockers, a whole host of medications can cause anorexia. And then constipation can also cause anorexia, like not having a good appetite if you're all blocked up, and anticholinergic drugs are famous for that, as well as opioids and other drugs with anticholinergic activity. And other drugs cause reduced nutrient availability, like, well, alcohol is a drug, right? And so that causes a whole host of nutrients problem. And antacids, proton pump inhibitors, can also block B12, folate, and iron absorption. Antibiotics can block vitamin K, colchicine, diuretics, isoniazid, laxatives. Like laxatives cause malabsorption, right? So A, D, E, and K vitamins don't get absorbed if you're on laxatives, and levodopa. So these need supplementation. So have to be thoughtful about what meds they're on, and the more meds they're on, the more problems with nutrient availability there could be as well. Monica, any comments on this?
I just would chime in about the antibiotics, because we got a question a little bit about gut bacteria. And so I would say that antibiotics are probably the number one or a primary factor that would influence the gut bacteria and what's available there. And so most of the changes is a lot of changes associated with gut bacteria can be related to those. And we know what infections, C. diff, et cetera, that can occur when patients are on prolonged antibiotics, and then kind of have a decrease of that healthy gut bacteria. So yeah, that's all I was going to add.
Next slide. Okay, for physical exam, of course, BMI is helpful, but look for skeletal muscle wasting, like sunken temples, right? Protruding collarbones, like we see right over here in this picture, you know, sunken ribs, sunken hand muscles, things like that. Look at non-healing skin wounds, pressure ulcers, functional decline, and clues like dry mouth, dentition, neurological diseases. That could be a hint to why they're having difficulty. And of course, no any edema, because this may actually mask weight loss. Right? They say, oh yeah, their weight's the same, but you know what? They have not so much muscle and a lot of fluid. That doesn't count quite the same. Next slide. I'll actually go back, and I just maybe I know Monica probably has stuff about anthropomorphics measurements and things like that. What do you like measuring?
Well, you can, weight is kind of one predictor. If you really want, you can do like an arm circumference or even calf circumference. But a lot of this is what I was sharing about that nutrition focused physical exam that registered dietitians can perform to help address some of these losses in lean body mass.
Yeah. All right. Thanks. Would you say that they're more sensitive to nutritional interventions that you might measure?
They'll benefit a lot from those early interventions. So a lot of the research on dietitians and identifying malnutrition early is that when we're triggered with that screening that was shared, the MNA, and we provide that early intervention, which could be as simple as something as honoring food preferences or offering soft foods. They have really positive benefits on like length of stay outcomes for patients and development of other complications.
Next slide. Okay, and these are just some of the nutritional screening labs. So if you see people who you're very concerned about, check your albumin, your prealbumin, look for low cholesterol, less than 160 milligrams per deciliter. And also you might want to also check those vitamin D levels, because repletion reduces falls, improves physical performance, bone healing, response to bisphosphonates, and I guess also COVID too, right? So next slide. Okay, so management principles, of course, as we talked about, there's just so many different causes. So we really have to be very diligent in figuring out, is this a psychosocial problem? Is it a, medication problem? Or is it, just a food access problem or a chewing problem? So you have to address the underlying cause. Just throwing, supplements at this isn't quite gonna necessarily solve it very well. Providing the right supplements, but don't over supplement with everything like specific vitamins and minerals and antioxidants. Those are not necessary, but really target what's deficient. What about high calorie supplements? Well, they may improve weight, but it may not actually change the outcome. And the reason why I have this picture here, because the principles, we can focus on the details, but really we need to focus on quality of life. Promote the whole purpose of good nutrition is to promote quality of life, mood, and functional status, because as nutrition goes down, their functional status and mood often goes down too. And so really just trying to focus on that with what's left. Next slide. Okay. I really want to finish this slide soon because we have so many great questions out there. Okay, so non-pharmacologic management need to cater to those food preferences, attendance to those consistency, color, texture, temperature, hand and mouth care, feeding assistance, avoiding excessive salt and sugar, herbs, spices. Give time, because don't rush them through it. It may take 2 hours to eat. Some people do, and that's okay. Address their cultural needs. Avoid therapeutic diets unless you absolutely have to, they just don't need their low cholesterol diets anymore. Yeah. Have a comfortable setting, increase socialization, and avoid hard to open packages. Or just a few, and we'll probably talk more in the Q&A about that. Next slide. And the other thing I just want to make sure to point out, this is from Choosing Widely, which is an initiative of the American Board of Internal Medicine. They have recommendation number 8 here, is to avoid the use of prescription appetite stimulants. All appetite stimulants out there on the market are actually off-label, and there's no evidence of improvement in long-term care survival or quality of life. And these things include things like mirtazapine and dronabinol, as well as on the Beers list with strong warning, cyproheptadine, which is highly anticholinergic, and Megace, which is might promote clots, and it's a steroid basically. Yeah, so these things they have long-term effects and bad side effects, so really should not be pulling these out for use. Next slide. Oh, and of course, I just want to mention that if you do have problems with nutrition, you will have problems with your red blood cells and your macrophages and your fibroblasts. And it's, the 20% weight loss is usually represents protein calorie malnutrition associated with impaired physiologic and immunity as well, and also associated with poor wound healing, infections, pressure ulcers, depression, functional ability, and mortality. And so repleting to improve these factors is what we're trying to do. to get towards better quality of life. Next slide. And then my final slide is that also from the Choosing Wisely campaign, and it's number 1 on this recommendation: don't recommend percutaneous feeding tubes. So no feeding tubes in patients with advanced dementia. Instead, offer oral assisted feeding. So yeah, basically careful hand feeding. It may take a very long time. It may be very, very slow, but that's better than tube feeding. And there's actually a YouTube video, which we developed at our GWEP, that you can actually, we'll put the link in the box and you can watch it on your own, and you can have patients and families watch that as well. And we have that in 3 different languages. Okay, here we go. Let's go back to the chat box, and we have a ton of great questions. So I'm gonna pull this here now. Okay. And so I'm also going to invite our hub people. So that's Mary and Sarah Tompkison. She's arrived here now. And so feel free to chime in and answer the questions as well as everybody else if you have other comments and experiences you want to share. So, okay, first question here. The GEMS document, we'll post that, Michaela, if you can do that. What about the overweight elderly? And does dairy not add more calories? What are your comments about what to do with overweight, malnourished elderly? Because that does exist, right?
Well, yeah, you know, and I was going to mention it earlier with elderly, there's actually slightly protective effects of having a BMI, you know, like 25 in that, sorry, Victor's very upset right now. Slightly overweight, it can be a little bit protective compared to severely underweight. And so with dairy, if you are concerned about calories, you can go for non-fat, low-fat options.
Okay, great. Okay, what do you recommend a 98-year-old who doesn't like water or milk? Chocolate?
If you're not worried about sodium, even a broth, warm broth, some herbal teas, if there aren't any kind of issues with that. But just think of other fluids and even some what we would consider food sources of fluids. So you could have soups, jello, even it kind of, you know, comes down to a fluid. So thinking of other kind of free water, not necessarily just free water in those typical beverages. And if you're not too concerned about blood sugars, if blood sugars are you can manage within their carbohydrate intake, 100% fruit juice or a vegetable juice is also another option.
Yeah, I had a patient who always liked, well, apple juice, she considered her cocktail.
There's a quality of life.
It was a quality of a life thing. That was every day at 4 o'clock, she had her cocktail and it was apple juice.
Oh, cute.
It's fun.
Yeah. Oh, and Dr. Cohn recommended hemp seed milk for those who don't like water or milk. I assume that's what you were referring to, right? And Dan, of course, eat the rainbow.
And protein and healthy oils, hemp seed.
Okay, do you want to comment about the soy? I have here, yeah. Soy must be organic, otherwise toxic. Non-GMO, and I understand that black beans are a type of soybeans. Do you know if they're usually GMO? Do you know anything about black beans? Are they soybeans?
I think they might all be in like a legume category, you know, but outside of that.
Okay.
They're all legumes, but I don't think they're the same genus and species.
Yeah. Yeah, there's lots of different beans. Yeah. How does the gut flora change with aging? Do you know?
I think we talked a little bit about, you know, that with the chronic antibiotics. That's the most I'm familiar with. And so if anyone else would like to chime in.
Well, I don't know. Sometimes when I have people on antibiotics, I just put them on yogurt every day. Is that just good enough?
That's helpful. And I think Leanne shared some other food sources of probiotics, like fermented foods, which also can help with some of that healthy bacteria. Yeah.
Mhm. Should people be on that stuff even if they're not on antibiotics?
I don't think it hurts,
So it was a sort of two-part question. One of them was, are there studies, or are you familiar with anything about the natural evolution of the gut flora with aging? Just in the normal course of aging, is there kind of a population shift in the gut flora?
I haven't looked into that, but I'm interested, so I'll look into that and I'll share what I find. But if others are more familiar, please share.
And then a follow-up on the probiotics, they're limited. So I was wondering if people could expand upon what they think are probiotics besides going to buy a pill. So that would be, yogurt and kefir and pickles, but pickles are salt pickles and fermented pickles. It can be hard to find a fermented pickle these days unless you really hunt it down. Things like natto or day-old poi
Kimchi.
are fermented foods, but what other? So yeah, there we go. Kimchi and sauerkraut and kimchi. But how about that thing about salted versus fermented? That old-fashioned fermenting is a timelier and more old-fashioned process for making pickles.
Right. Yeah. So not that quick pickle type that we always get. Absolutely. Yeah.
Okay, we have a comment about Nestle is one of the most toxic companies on the planet. What's your favorite supplement, Monica?
Oh, my favorite, when it comes to favorites of things, I always say my favorite thing and the healthiest thing are the things your patients will consume, right? That they have access to. So we talk about like the best vegetable or the best supplement. My grandfather in his last years was not in the best nutritional status, and every flavor of Nepro, it didn't matter. He did not drink any of it. So our best intentions, we made him milkshakes. We just had to make them. So I think working with your patients and really spending the time to find out what they will actually consume is probably the best approach. I know nobody likes that, but that's what I say.
I know it. One of my facilities I was in a while back, we created this super cereal thing where it's kind of like oatmeal, except we added everything to it, like peanut butter and anything you could think of, right? And just sort of beefed it. Adding protein powder to it and adding a little bit of healthy fats and just add everything to it, and then it's like you pack more for the punch.
Right. Yeah. Exactly. So being creative with those types of things is good.
And chock full of their favorite things, I guess. Curious to why BMI less than 17 instead of BMI less than 18.5, and why 10 pounds instead of 10%. Is there a different resource we should be referring to?
We should be looking at the 18.5 and the percent weight loss, really.
Okay. Okay, great. Well, I was just looking at the AGS gyms. So, but that's good. So better to catch it early, right? Not wait till it's super late. Glyphosate is an antibiotic? I didn't know.
It was originally approved as an antibiotic.
Oh, okay. Thank you. Yes, Sarah.
Which means
here.
it kills gut biome. And that's what most of your GMOs are protected against. Glyphosate is Roundup.
Basically, I put my
weeds to get commercial farming uses Roundup to kill weeds and to sterilize the soil so that they can control everything. Very unhealthy.
Yeah. Wow. Amazing. So yes, grow organic if you can. So Sarah, I know that you just joined late, but maybe if you want to share anything, if you have audio, if you want to share anything about your experiences on what you talk to families about when you notice what gives you the most bang for the buck? How do you? Figure out malnutrition? Oh, I don't know. I don't hear her. Okay, so Dan, what recommendations would you have to be stored? Okay, healthy. Okay, we just talked about that, right? Great. And probiotics, good. Can be, we talked about that. Okay, history of meds, supplements, and meals is important. I had one caregiver giving meds, then ensure, then offering the meal. No wonder the patient ate less than 50%. And switching the order really helped. Absolutely. I see that all the time. People just order, Ensure TID, and then, yeah. I have to actually write the order to say after, if they eat less than, 50% of their meal or something like that. Because if you just give it to them with their meal, it's, yeah, not going to work. Okay, Michaela posted the video, a link, so you can take a look at that and share that with your families as well. Okay, so Joseph Cohn comments, commercial corn products, derivatives containing Bt toxin. It's an aggressive toxin that damages cell membranes, kills insects by literally making their stomachs burst. Oh, okay, so.
Sorry, the one thing I was going to add about the fluids is that we should think about, all the fluids with the meals, and consider timing fluids in between meals and to encourage intake of food versus filling up on fluids if there's like no calories in the water, for example. Yeah.
Mm-hmm. Okay, great. Yeah, so I guess Joseph is putting in another plug for organic foods as much as, I think, growing local would be great. I think all of us are now having pandemic farms, right, in our own gardens. So, but not everybody is able to access this. So I'm gonna call on Mary Gotham. You are a longtime public health nurse. What are some practical tips that you give people, like for how they can improve their diets on very low budget?
Yeah. Well, I just say we would get referrals on a lot of people that have, real bad malnutrition problems, and it's a real challenging situations to intervene on, because a lot of times it's like you said, so many different reasons why they are not eating properly, and to solve it is a real challenge, because a lot of times they were just living alone, they didn't have anybody, and they're alone, all the things, everything multifactorial is affecting it. So it would really be each person would be individual, and you try your best to think, what can you do to make it better? And it would be all kinds of things that you try to think of for that person to try to improve the quality of life so that they would want to eat, and those kind of things. So sometimes it would be Meals on Wheels referral. Sometimes it would be maybe if we could get a senior companion assigned to be with them a few days a week to have lunch together with them. It would just be all different kinds, whatever we can think of to try to help this person, increase their intake and eat better foods. So a lot of times, if they didn't have money, that would be a problem. So a lot of times, Meals on Wheels was the savior. I don't know how it is nowadays.
Yeah, we still have, Meals on Wheels is a great option. There's even before COVID, there were a lot of congregate meal, settings, so that they could get their free meal and then have some company, and also different activities. I know Lanakila Meals on Wheels here in Oahu offers that service. Something new we've been doing, I teach the dietetics courses at the university, and something we do in our case studies now is this called a culture hub or culture wheel, but we kind of consider all the social, environmental, cultural factors that are influencing our patients and try to identify the strengths. So assessing their connections with other people, with other organizations, the places and things that they have access to where they live or go, and trying to identify where are those strong connections that might be able to support nutrition. So maybe they have a really good friend that lives just down the road, and maybe that's the person we can kind of try to encourage to be part of that support for nutrition. So kind of trying to find those strengths.
Yeah, I just want to comment that support for nutrition is really critical. I mean, sometimes, I have patients who get admitted to a nursing home, and it's because they didn't have that nutritional support, and all you needed was somebody to actually be able to spend the time, that 2 or 3 hours per meal, and they'd be fine. They just needed that additional support.
Yeah.
Okay, so let's see, I have here, raw veggies. You want to comment about raw veggies versus cooked veggies?
Raw veggies have more probiotics and in them. A carrot is loaded with probiotics because it, even when you wash it, it's got enough soil bacteria in it that it can actually reestablish the microbiome in the gut flora.
What about kombucha? Do you know much about that in relation to this?
So it would be another good source of those probiotics. Yeah, just what, yeah.
Okay.
And it's also fluid, right? Helping to get those fluids in.
Right. And yeah, Sarah has problems with the audio and visual right now, but she's commenting in the chat box. She likes Dr. Tom's comment about engaging family caregivers in assessing appetite and being that care partner too. Sometimes if, whether they're in the facility or not, if you have to just have somebody dedicated for lunch, say, and just say, hey, can we have this one person dedicated to spend hours for lunch? Even that alone might be, helpful. And yeah, and families typically know what their favorites are, or not. Oh, the Ann Crow is putting in a link for an article on gut flora with aging. Okay, I'm gonna have to click on that and check that out. Okay, and Sarah Tompkinson is saying, I think the challenge is finding a balance between embracing our cultural values about eating, but at the same time not forcing our kapuna to eat. It is so, yeah, I mean, that's why I put that thing up there, it's quality of life, because otherwise we say, oh, malnourished, and that's all everybody thinks about. And they forgot about the quality of life. Like, don't force feed me. I don't like that stuff. I don't want to have all this extra stuff. Just, give me my favorites. Yeah. 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 And of course, again, not subsidizing commercial ag, subsidizing organic, growing organic, always better. Sarah says, spot on, Mary. Eating is a social activity. Who likes to eat alone?
Right. Yep.
And that's one of the reasons against tube feeding, because tube feeding is so easy. You just hook it up and walk away, and you actually deprive the person of that one-on-one, slowly but surely, one bite at a time interaction. So, yeah. And Michael Tom says, Meals on Wheels is awesome for many of our seniors. It is. And I know that Mary can attest, she did that. She was attesting that it is powerful. So,
yes.
Yeah.
And even sometimes the only interaction they get is when the person delivers it. So
true. And oftentimes,
sad.
Yeah, and those guys are also, they report problems like if they've fallen or if you're not answering the door, right? They're good eyes and ears in the community.
That's true. Yeah.
Okay. More plugs to supporting their local farmers. Good. Okay. And thanks to everybody. People, Monica, okay, Sarah comments, people look at food differently. There are those people who live to eat and other group of people that eat to live.
Absolutely.
Absolutely.
I agree, Sarah.
Mhm. Yeah, and yes, there's a good comment about raw vegetables are difficult if you have dentition issues. And so that's why trying to find vegetables that are or fiber or other things that can be pureed, right? Or soft. So there's many different, juice. Yes, if you have a juicer. Oh yeah, smoothies and juices, right, are really great ways to get nutrition if you have dysphagia and trouble eating. Yeah. Great. Oh, is that it for the questions? Oh, wait, it is 12:57 already. Time flies when we're having fun. Any last minute comments? There is okay, Michaela posted in the chat where you can get your CME, so make sure you fill out the evaluation form. And you have to indicate the type of CE you would also like, and also put your comments as to what kind of future programs you would like to have. And next month, May 12th, we're going to be talking about palliative care and hospice care. Wondered about what the difference between all three of them is. Come join us next week. We have Dr. Ray Seitz and Jeanette Twigane going to be speaking about that.
That'll be good.
Yeah, so wow, thanks everyone for all the great interaction, the great tips. And I have a feeling we could have gone on for another half an hour at least.